it doesn't matter how many Instagram followers you have, but science, what you put on PubMed, for instance, this is hard work. This is super hard work.
If today you could change worldwide one habit in implant dentistry, which would it be and what would be the impact?
The almost unrestricted usage of CBCT scans. We overexpose patients in a way where we don't see a clear clinical benefit.
I think you have a very high sense of responsibility for, let's say, the patient community.
Dementia correlates with tooth loss. So when you re-establish the chewing function by means of implants, you even counteract the degeneration of cortical areas.
Welcome to ProTalk. Welcome to the Pulse of Dentistry. Welcome to this episode where George and myself have the pleasure to welcome a guest, a clinician and a scientist actually, that has shaped not only our thinking about implant success, but also its limitations and limits. Very happy to have Professor Frank Schwarz from Frankfurt with us. Welcome, Frank.
Thank you. Thank you.
Good morning, Frank.
Good morning. Good morning.
Frank, today we will speak about, of course, the tremendous success that implant dentistry is. But there are limitations as well. We will speak about those limitations. We will speak about peri-implantitis. This is a reality and it's happening, and we have to speak about its etiology, prevention, diagnosis, therapy. And with you, we have one of the leading experts in the field, but you are more than this, than an expert in this field. We will also speak about, of course, innovation and, the tension of, let's say, between innovation and clinical reality. So very happy to have you, Frank. Good morning. Frank, first question we always ask is, who is Frank Schwarz in 1 minute?
Yeah, that's the tricky one. Well, because to define yourself as a person is always critical, because you always see yourself from a different perspective and usually not the way other people look at you. So I describe myself as a person who is fully dedicated to details, to professional approaches, to trust, to confidence. I'm very much into team working. I'm very much supportive for younger people who are striving for, let's say, the next steps in their career. And this is what characterizes me and what drives me most. Yeah. As a private person, I'm dedicated or fascinated about aviation. So this is where I spend most of my time.
Okay.
That I have. So putting me in the airplane is for me the best place where I can be. Because this gives me this feeling, this sensation of an exceptional environment. So what is football for you? It's aviation for me, as I've learned. I have unfortunately not that time to spend with my family, because our business is really demanding time-wise, as you know. Yeah. But all in all, I'm a quite regular, a normal person, yeah, and that's why I put too much time into my profession, and that's what characterizes all of us here.
Yeah. Aviation is actually a very interesting topic, and that I see a lot of parallels. What transfer do you get from looking at aviation into your professional life?
Well, it's not linked to my profession. So I think aviation is something that, of course, where you start maybe as a teenager, yeah, becoming a pilot, which was actually my dream, but it never came true. Of course, it also goes along with what we are doing. We are traveling a lot, and this is something that attracts this innovation, something that comes, I would say, from the outside. So this is something that you cannot reach, yeah, because this is something that you don't have in your day-to-day life. Yeah, it's exceptional. And this is something that attracts me. Of course, from the perspective of our job, a pilot, they have checklists, they try to avoid errors and failures, and I think they are perfect in this.
Mhm.
Yeah, so the success rate
Yeah.
or the survival, let's put it that way,
Yeah.
from our
Yes.
outcomes perspective is exceptionally
Yeah.
high. Yeah,
Yeah.
and the link to peri-implantitis, of
Yeah.
course, maybe a checklist is also something that we should put more into our routine.
Exactly. Protocols, checklists. I
Yeah,
think there's a
yeah,
lot of
yeah,
actually analogies there.
Attention to detail.
yeah,
I think, yeah.
Absolutely. Yeah. Learning,
yeah.
a
Mhm.
very meticulous way to learn from mistakes.
Yes,
And teamwork. So
Teamwork. Yeah.
yes, yes.
Frank, you mentioned soccer. In soccer, intensity is becoming a big word. To play with high intensity. And I see you playing your career. We know each other 20 years now, and
Yeah.
I mean, you play with a very high intensity and a very high quality in many fields. You are a clinician. You are a researcher. You are an educator and a speaker. You are very active in also associations, in leading roles in associations. That also takes time and efforts and, let's say, uh, attention to details. What is the bigger purpose for you behind this? Why do you play this so intensely in this completeness?
Yeah. So what should always be the main driver is the academic basis of dentistry, and we will discuss about the term maybe a little bit more in detail, because dentistry is not the way I would put it. So it's more oral medicine, but the academic basis is something that is essential. So education is always driven by research, and the academic basis of medicine, of dentistry, is research.
Mhm.
So and that's why the main driver is research. And research is something that is, of course, coming from the institution, but you need research support, you need exchange, and that's why
Mhm.
the main driver is always research
Mhm.
to drive to establish the academic basis.
Mhm. Where do you get your research ideas from? Where do you get this inspiration from?
Yeah, I get it from the industry, I get it from the exchange with other people, and also from the patient's
Mhm.
perspective. Yeah,
Mhm.
The clinical work.
the clinical
Mhm.
work, and that's why the translational part is really important. So just working in a lab, from my
Mhm.
perspective, can never reach the real target, the real needs of a patient, because you don't get the feedback.
Mhm.
Mhm.
Yeah.
Yeah.
So clinical research is the fundamental basis, but without having the exchange with basic research, with basic science, you will, of course, also not proceed.
Yeah,
So at the
absolutely.
end, you need to
Mhm.
exchange, to discuss with people from different fields.
Or it will remain shallow
Yes.
at the end.
Yeah.
Absolutely. Yeah.
Yeah.
How do you balance this with your private life? I mean, the intensity is high, and
Yeah.
you do with. It was nice how you described yourself. That's also how we perceive you, with precision and details and perfection and doing things right. So it takes a lot of time as well. How do you balance with your private life?
Yeah. So there is no private life from that perspective, because you can never stop. Yeah. So in these days, a typical, let's say, work days, you work at the university, you have patient service, you have education, you do the research, and towards the evening you have meetings in these days with the Zoom meetings. So this is actually never ending.
Mm.
Yeah. So you have to define private life in a different way. I'm not talking about family life. I'm
Mhm.
talking about your private life as a person. Yeah.
Mhm.
And our profession, what you do, becomes
Mhm.
part of your private
Mhm.
life. Otherwise, you
Mhm.
couldn't succeed, because the day has 24 hours.
It has 24 hours. Yes,
Yeah.
absolutely. Yeah.
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 So you're not making basically this clear distinction, because it's your life. It's
Yes.
work
Mhm.
is part of your life, and it's also what you're probably fascinated by. So
Mhm.
it's also giving you energy. It's not just
Work.
draining you,
Yeah.
right?
Yeah.
Well, this trend word, this work-life balance. So this is something I think this is nice, and you can discuss about it in many different ways. But if you say work-life balance means that you work 6.5 hours per day, and then you make a full stop, and then you enjoy your private life, this is something that I could never imagine that could ever come along with the progress, with the career. So you have to spend many years far beyond a 6-hour or 7-hour workday.
Absolutely. Yeah,
And
exactly.
this can never happen if this what you are doing is not part of your, let's say, desire. This is not something that you would like to do. You will never succeed.
No, I fully agree. I think it's a bit a reoccurring topic. People, guests we have in the podcast, success is not coming by itself. It's not,
Yeah.
you will not
It's
have
hard work.
a 4-day
Yeah.
week and have a beautiful clinical career or research career or academic career. That's simply not possible. Same is true for us, probably.
Yeah.
I looked on your social media profile as well, which you have, and we are connected. But what I observe is, Frank, you build and maintain a very science-driven, let's say, image as well, and that is where I feel you put your focus, whereas others are building, huge, let's say, Instagram channel, and there is nothing right and wrong.
Yeah.
But I see you
You
took
think
an,
so?
let's see.
Good discussions.
Oh, yeah.
But
It's a good point,
the
Andreas.
question is it a deliberate choice
Yeah.
that you did, and why did you do it?
Well, I give you one example. I was really shocked. I will not name any names and not even the society. A big conference in my session. The chair of the session announced the next speaker, and he said, well, let's welcome the next speaker. He is blah, 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 and he has 35,000 followers on Instagram. That was the introduction. And I was shocked. Because in my mindset, it doesn't matter how many Instagram followers you have. In the past, it was this person has so many publications, has reached these, let's say, these goals.
Yeah.
He's standing for the topic, whatever. But the Instagram profile become all of a sudden a major part of the announcement. And I was reflecting it very heavily. And at the end, I was shocked. Because Instagram is something that you can influence in different ways, but science, what you put on PubMed, for instance, this is hard work. This is super hard work. And again, going back to the academic basis, this establishes the academic basis of dentistry, oral medicine, of each and every discipline.
Yeah.
Instagram does not.
No, it's not a qualification criteria.
Exactly.
It's if you have the quality and the content and the depth, it might be a channel that will help you to disseminate ideas, probably. Not in a very much a depth, but in a, let's say, more broad way.
Yeah. But on Insta, well, you see it all over the place. People are. I'm not against it. It's part of the new wave. I think this is important, for this global outreach, for the communication, super important. But it shouldn't come as a first step.
Absolutely.
The first step is doing research,
Yes.
spend time, dedicate yourself, find your way, and in the next or the over next step, you put Insta, and I think then it makes sense.
Yeah, to disseminate quality
Yes.
and not just
Yes.
flip it around.
Yes,
Exactly.
yes.
Yeah, no, I agree.
And advertising yourself, promotion of yourself is, I would say, it's not the best way to proceed.
No, 100%.
Yeah.
Yeah, that's an interesting topic that probably we could spend more time on, and maybe later on we have the chance to also discuss a bit there. So Frank, now let's also move a bit into implantology. And Andreas, you mentioned before, so implantology in the last 3 decades has become very successful. So also if you compare it to other medical treatments, I mean, we have high success and survival rates. We talk about 95, 98%. We have 10, 15, 20 years data. And it looks quite promising. So a lot of patients are actually receiving implant treatment. Now, on the other hand, things go wrong. And I think this is where you also spent a lot of your career dedicated to, figuring out what can go wrong, and if it goes wrong, how can it be treated? So the whole peri-implant complications, mucositis, peri-implantitis, is a key topic of what you're standing for. Maybe let's go back to the beginning. I would wonder, was there a specific moment where you decided, okay, this is something I want to dedicate my, let's say, my life, my work theme on? And what was it? Was it a specific patient? Was it a conversation that you had with colleagues? How did it come about to really focus that much on this topic?
That's a very good question. So I studied dentistry in the southwestern part of Germany in Homburg Saar, so it's a quite small town. At these days, Tony Skuljan was my supervisor, so this is where I got to know him as a dental student. And we had a brainstorming, and he said, well, peri-implantitis, so infections around the implants becomes more and more popular in the literature. So we are talking about maybe a handful of publications.
Mhm.
And I said, let's start it. This is a good topic, so maybe we should establish a basis on implants and infections. But the reality was, in that small university, in that small city, I have rarely see patients with implants because just a few
Wasn't that
numbers.
popular yet? Yeah.
It was not popular yet. Yeah, and I'm talking about the year 1999.
Mhm.
Yeah, so it was the right topic at the wrong place. A couple of years later, I moved to Düsseldorf, and Düsseldorf was the opposite. Many implants, many patients, and all of a sudden we have seen peri-implantitis at its best in the clinic. So that was the right place to start. So the need
Mhm.
to tackle a problem that was apparently a problem, even at these days, 2004.
Mhm.
Mhm.
Something that, I often get the question is, how do these two things actually come together and make sense? Because on one hand, survival rates we have very high, let's say 95, 98. On the other hand, if you look at prevalence data of complications, it's also quite high, right? Depending on publications, 20, 30, 40%. So how do you bring this together, and are we systematically underestimating the complications that actually can occur with implants?
Yeah, we have the two worlds. We have on the one hand side the clinical reality, what is happening in our university, in the office next door, and what is reported in epidemiologic data. So epidemiology always means you have a convenient sample unless you're talking about registries such as in Sweden, you have a well-established registry, but even those data are just reflecting the situation in Sweden. So it's really super hard to transfer epidemiological data to day-to-day practice. So that's why when you see a complication rate, a peri-implantitis prevalence of 30% in epidemiological studies, it doesn't mean that you will see it in your office. So that means practically, I would say yes, the tendency is always we underestimate the problem, and this is hardly, I would say, justified by those data. But in essence, I would say the numbers are much higher.
So now what's the essence of it, Frank? So is it that we have a real problem in implantology, or can we actually maintain the status quo?
Yeah.
And we do have also treatment options today that are well suited to to still be very confident in promoting also implantology.
Yeah. So I think that's the point. If you put it that way, peri-implantitis, 1/3 of implants are affected, or let's say 50%, you would say 50% of the implants are lost and are big complications. And I would say this is definitely not the case. Only a very small subset, percentage of those 30 or 50% are really hard to treat, hard to manage. Most of these can be resolved quite easily and maintained, so even the patient will not even notice it. Unfortunately, some dentists will also not notice it. But overall, the projection of a tsunami of complications is what not really matches the clinical reality. So I would say, even if you have 1/3 of implants revealing signs of inflammatory reactions, only a subset of these implants are really critical, complication related in your day-to-day practice.
I'm sure that you're seeing some patients, some cases
Yeah.
coming to you, and then you say, okay, this could have been avoided. And if you see those cases, what is the main root cause of these complications? Is it more in the planning? Is it in the execution? Or is it in the maintenance phase of a treatment?
Yeah, All of these components are critical in the planning phase, of course, but the planning phase is in most of the cases quite well because we have now digital planning. We have so many tools that facilitates this first step. So most of the complications come now in the execution phase when you put the implant in a non-ideal position or the bone is not that, let's say, perfect as you would like to have it. So you have a compromisation during the execution and the maintenance. So this is what many people underestimate. It's quite boring, but you have to see your
Maintain this.
patient many times
Yeah,
and you have to clean it.
absolutely.
So for a surgeon, this is something that he
That's so
doesn't really have
interesting.
on the
Yeah.
radar, but that makes the difference. And even if you don't do it, you have to delegate it. You have so coming back to your question, it's not necessarily the planning phase, it's more the execution and the
And the
maintenance.
maintenance, yeah. So in the last decade, where would you allocate the biggest advancements in terms of treating peri-implant complications? Is it then in the maintenance phase? Have there been better tools developed? So where do you see the biggest advancements in that field?
Yeah, the biggest advancements are definitely in the definition of risk factors so that we know which patient has which profile, that we better understand which factors influence the treatment outcome. And some of them are still hidden factors, so we have just small evidence, but all the immunological parameters. So each patient has a fingerprint, an immunological fingerprint. And this is something that you can't see by means of a probe or by standard tools. So you need to go into more advanced analysis.
Yeah.
So, and this is, for instance, a cytokine profiling. This is something that can be done easily. And we have specific cytokines, we have specific cell types that are linked to a higher risk profile than others. So identifying the patient more from the immunological perspective is one advancement. And this is something that is established, but can hardly be used because the technology is not available in day-to-day practice. So it's not always the surgeon who to place the implant in the wrong position. It's more the immunological component.
Okay.
Yeah.
So do you see the chance that actually those technologies will become soon available also for let's say, general practitioners? Because they are more complex and it's not easy accessible today. But are there advancements that you see to actually make this more prominent for general use?
I hope so. Well, this is your job. You are from the industry side, I think chair-side testing is something that you can easily establish for major cytokines such as interleukin-6, for instance. This can easily be assessed chair-side. So, and that would help tremendously to monitor a patient. How is the immunological status? So that would help tremendously. And yes, of course, this can become available within a short period of time, but the awareness is important.
Do you have the feeling, I mean, listening to you, planning, treatment, then also, let's say, the handling of complications, and in between is actually the maintenance. Do we underestimate the maintenance phase? I mean, do you feel it's clear enough, the guidance is clear enough to clinicians out there and to patients, how to do a proper maintenance?
I think this is well understood. This is well described in all the guidelines. I think there shouldn't be any lack of knowledge. So this is just the execution. How can you implement such a maintenance program in your office when you are just placing implants? So it's all about the responsibility. Who takes the responsibility for the maintenance? And I think the delegation would be one option. But at the end, that's the clear duty of a dentist. Yeah. So he needs to delegate it, or he has to do it on his own. Yeah. But from that perspective, it's more the execution and the diagnosis that leads to the maintenance scheme. Yeah. And it's not just cleaning. It's knowing that this patient is a diabetes patient, is a patient with a high immunological risk profile, and this patient needs to be handled in a different way.
So closer follow-ups.
Yeah.
What is your opinion on, let's say, at-home monitoring? So is this something that we can, put patients in the responsibility, or is that rather difficult to actually get the maintenance done not in a clinic?
Well, a good example with my watch. I track my sleep, I track my training, I track my stress level over the day. So in the evening, and I can easily get access to at least 50 parameters that describe me as a person, how I perform the day.
Based on data.
Based on data. So it's very simple and easy to monitor even oral health related parameters with all these gadgets, with all these tools. I think this step is so simple and small. So monitoring at home is exactly that domain. So in the future, a patient should get at least some parameters that reflect his oral health status. Not a bleeding score and not a probing depth of the implant, but
Can you please check my
yeah, but
partner?
it should give him at least the awareness that parameters related to the oral health status are
Inflammatory.
In
yes,
line or
yes, or are at least in the awareness. And I think this is something that can easily be established, very easily.
Okay.
Yeah, so that would help. That would help to, let's say, not just to avoid peri-implant diseases, but also to generate more the awareness of oral health related quality of life. And that's why I started with at least a short notice on dentistry. Is not the appropriate term of what we are doing. Yeah, it's oral health, it's oral medicine.
Yeah. Let's connect the discussion a bit with your activity in the really big associations in implant dentistry. And I mean, in Germany, the DGI, German Association for Implantology, the EAO, that you've been, or you have a board mandate, ITI, osteology, and congratulations for a great osteology congress just recently, Frank. So how do you see the role of those associations going forward? What is their responsibility, nowadays in implant dentistry to help clinicians, moving in the right direction and to give them kind of guidance and navigating them through the complexity in implant dentistry?
Well, education is important. You need to establish, I would say, a certain ground, a common ground for the surgical skills, for the scientific basis on how to properly perform implant dentistry as a practitioner. I think this is the obligation of these societies to define a certain standard for clinicians. This is one domain, and I think this is what all these associations are actually doing, and foundations, they establish standards for patient service and for implant dentistry as a discipline. And the second, of course, they should ideally, and this is what they also do, support research and to provide young people, next generations, a platform where they can grow, where they can become leaders in the field. And this is something that you cannot become just based on Instagram. You need, of course, a society, a foundation that gives you certain programs. And I think this is such a beauty that we have these associations and foundations in a very positive way.
Yeah, you're also part, I would say, almost a standard guest in the consensus conferences where you take, you really dive deep and, you take evidence-based decision and give clinicians guidelines at the end, what to do, what not to do. How do you see these consensus conferences evolving? Because, I mean, each of the associations has one. Now there is, let's say, a tendency to unite these consensus conferences. How do you see this evolving?
Well, guidelines are terrible because digesting a guideline is the most terrible thing that you can do as a clinician. On a Monday morning, you have a 100-pager and you have a real problem in your chair.
And you need to find the right
you need to find the right conclusion. And the conclusion is in many ways, we don't know because the evidence is not enough, not sufficient.
Need to do more research there.
We cannot make a clear recommendation. And in other ways, you have a recommendation that is likely not what the clinician expected to be because his reality is a little bit different. So that's why you have to find a sweet spot that a guideline is a very dominant word. You have to do it that way. We guide you because you can't do it. So this is what the guideline implies. And that's why if you look at a guideline from that perspective, it's terrible. But a guideline has also the sweet spot. And the sweet spot is it gives you a background on the science, on the evidence, and ideally, it gives you a clinical advice that you can follow, that you can understand, and that you can implement in your office. And that's why this global initiative, this global consensus for clinical guidelines had exactly that vision, that focus to be more in the reality, also putting the patient into the perspective, because if you don't ask the patient, you can, of course, not succeed because the patient needs to be involved. And that's this global perspective, the streamlining of activities of different societies, and this GCCG project was a beautiful first step.
Good. Do we miss an open evidence type of tool? If I listen to you, I wouldn't read through 100 pages.
No,
I
me
would
neither.
like to have, but are we in dentistry missing like an open evidence kind of a tool?
Well, we are in dentistry, our evidence level is quite good. So compared to other medical disciplines, we are quite good when it comes to high evidence level studies. I think this is where dentistry does a perfect job. Yeah, but the translation is the important thing. Yeah, because for us, we are doing many different steps at our patients. So you have a step 1, step 2, step 3, step 4, and this is what a medical doctor not necessarily has. He prescribes either the one or the other drug, and the guideline tells which way to go. But we have to define 20 different steps just for one treatment procedure. So these technical details that make it so difficult. Yeah.
Maybe before we move a bit into the field of innovation, Frank, I have a question. If today you could change worldwide one habit in implant dentistry that you see, and maybe you think it's not the right habit, which would it be, and what would be the impact?
You mean habit?
A bad habit.
A bad habit. So what clinicians do or what patients expect?
I leave it up to you.
I don't think we have a bad habit. But one bad habit is definitely the almost unrestricted usage of CBCT scans. So this is something that I see as a major fraud, because we overexpose patients in a way where we don't see a clear clinical benefit. So this is one threat, and the other is, of course, the multiple usage of systemic antibiotics. So this is where dentistry massively contributed to the resistances that we see for many, let's say, clindamycin. This is one thing that is hardly driven or mainly driven by dental applications.
I remember you saying the contribution of dentistry to the radiation doses
is massive.
Right?
You can measure it. Yeah, you can measure it in the meantime. In the past, we were in the bubble of the overall exposure. Dentistry was neglectable. But with the introduction of CBCT scans, we became a key player in the field, and that's why we have to we have to rethink. So what is for the benefit of the patient, and what is not for the benefit? And CBCTs are nice for us, but the patient has hardly a benefit.
That's a good food for thought.
Yeah, and that's why maybe MRI
in the future could.
In the future, from that perspective, I think this is the innovation maybe that we will discuss later on. But in essence, at least critically thinking about the patient and exposures is important. And exposure is also antibiotics.
Perfect segue to the innovation topic.
Yeah.
So let's also talk a bit about the future and how you see this, Frank. So to start with, maybe an example. What is a recent innovation that you, after careful consideration, adapted in your daily practice?
So it's not a recent innovation. Yeah, for me, it took a quite long time to build more on guided implant placement. So for me, that was something that made my life harder and more complex in the past. But in the meantime, I highly appreciate the comfort of having a template, putting the implant. So this is not a recent innovation, but the innovation that took a quite long time to convince me. So you can hardly find an innovation that you bring on the market and say, this is something new. And I'm not an early adopter when it comes to clinical or to devices or technologies. I'm a super early adapter for, let's say, for electronics, but not for things that are related to my daily work, because I'm very conservative, because I'm not changing the way how I treat and manage cases from today to tomorrow. So I'm always spend some time to rethink and to really look for the benefit for me and for the patient.
Maybe an overlap between electronics
Yeah.
and still dental. So what's your opinion on this future possibility of dynamic navigation and robotics? Is that
Yeah.
something that you also have already gained some experience, and what's your opinion?
So the opinion is, I would say, this is definitely the future. So not necessarily for me, but for the next generation of dentists, they will have to deal with robotics. They have, of course, to be open-minded. But again, this is something that works scientifically. So we have many studies, we see it works. But will I be able to implement it in the next 5 to 10 years in the routine? In my clinic, I would say maybe or maybe not. Yeah, but definitely on the long-term perspective, this is a game changer for sure. Yeah. So again, it took me about 10 years
For the guided surgery,
to
yeah.
build on guided.
Yeah.
I'm talking about 50% now, 50, 60% of my cases. In the
Okay,
past, I
yeah.
was about 5, but now after many years, I'm at 50, 60, and it goes up.
What has made change your mind? So what convinced you basically on that principle? Is it also linked to what we discussed before in terms of being very conscious about the planning and how
Yeah.
to place implants?
Yeah. Yeah, there are many components. I think the most relevant is always how easily can you use it in your day-to-day
Exactly. Yeah.
routine. And in the past, for me, I had to do the planning on my own. If you don't do the planning on a daily basis, it's really hard. And that's why now we have a scheme where we have established workflows. It can easily be implemented. And of course, if it's easy to reach, then I'm, of course, get favor of it. Yeah. So it's always how can you implement the technology in your day-to-day
Needs to be
workflow?
practical
It needs
and
to be
not
practical.
taking too much time.
Exactly. Yeah. It's the same when you like to eat fruits. Yeah. But thinking about eating fruits, you have to buy the fruits, you have to cut the fruits. Yeah. And if there is a buffet and the fruits are
It's much
just
easier.
available, of course you eat the fruits. And this is like this, or quite similar with these technologies. They are difficult to implement. And if you find a way to implement it, of course, it's a deal breaker.
And I think this is also exactly the way that dynamic navigation has to go, because right now it's still a bit cumbersome for the benefits. But if it becomes easy enough to just use it, I think it will be a no-brainer to actually know where you are.
Yeah.
Simply speaking. So a lot of dental innovations in the, I would say, last decade has to do with becoming more immediate in terms of treatment. And I think this is also linked to a patient wish. So this instant gratification, I would like to have my treatment done as quickly as possible. What's your opinion on this one? Do we reach certain biological limits in terms of making treatments faster, reducing treatment steps? Should we be careful to even push this further? Or do you still see some room to go?
So I'm very positive about going beyond the limits. So biology has, of course, limitations, but I think with the conservative approaches that we have established in the past, we are far, far beyond what we can do. So immediacy is something that I would say does not push us the limit of the biological system. So because if we don't interact, we lose tissues. This is what we have seen. We get a remodeling, we lose, we have to build it up again. So if we are at the level of the biological process, I think immediacy is exactly at that level. Yeah, we place the implant along with the tooth extraction, and the biology comes along. And I think this is an example where we are lacking confidence, because many colleagues still think that we are pushing biology, but I think we are at the level of the biological process with these technologies. Yeah. So you don't have to convince me at all. So I'm a big supporter of immediacy, but I know many people have a conservative mindset, and conservative doesn't always mean that it's the better side. Yeah.
Well,
So
it's very
immediacy
positive.
is not too pushy.
Yeah.
And this is what we see. Of course, this also took a long time to see that this is not an experimental procedure. So it's biologically driven, and it's the best possible way to support the tissue during the repair and regeneration phase.
It's very positive to hear. I think we are at the same level. I think it's still not the end of the story. So there is so much that we can do, and also we're always surprised by the biological responses of the body that actually can help us to do much more. And also being too long without any, for example, mechanical stimuli, it has of course severe consequences also on tissue maintenance. And I think it's good that this is now an established understanding of in implantology as well.
Of course. And this is something, from my perspective in dentistry, what many people have too well established. So many people are acting according to what they think and not to what they know. And this is a difference. So is this what you think, or is this what you know? And
This is where the research comes in, right?
Yeah, if you think that the conservative way is the better way, just because it is conservative, then it ignores the fact that you don't know that the opposite is the case. So, and knowing is about having a proper understanding. And this is where dentistry in general is very conservative. We are basing our procedures too much on what we think, because this is how we did it in the past. So this disruption is very hard to achieve. And you just brought up this immediacy thing. So this is nothing new. So this goes back decades. So immediacy is nothing new. But now the people are
it takes a long time
knowing that
to establishing it.
there are advantages. In the past, they were thinking that this is a bad way to go. So knowing and thinking. And again, this is the research component that makes a difference.
I'm still going to ask you about what you think in terms of future, because we don't know yet. So, Frank, what's your view on, let's say, dentistry in a decade from now, so in 10 years from now?
Yeah.
What are we going to have in that period which we're dreaming about today, and it might become a reality?
So I know, and this is not what I think, I know. No, I definitely know that dentistry becomes more and more part of the medical discipline, because we have now so many, let's say, connections that are so essential for the medical field. And of course, you are maybe now a little bit more focusing on technology side. Let me just put in the first step the biology. And the fact is that oral infections, and we are mainly dealing with oral infections. You have named just peri-implantitis, we have periodontitis, we have dental abscesses. So we have so many inflammations. We have also immuno-related lesions in the oral cavity, and they are all drivers for systemic inflammation. So this is nothing that we think, this is well established. So the most recent one is the oral gut-brain axis. So bacteria coming from the oral cavity, penetrating into the gut, and from the gut to the brain. So neuroinflammation, neurodegeneration, these are just some of those links between oral medicine and medicine in general. So this is something that will definitely evolve in the future. So this gives us more medical relevance. And this is also part of the industry. So support this procedure by diagnostics, by tools that helps us to monitor inflammation, systemic inflammation, chairside in day-to-day practice. So this is one component, and I know that this is on the way, and this will be one of our main future pillars in dentistry. So the second is more the technology side. And well, you are a major innovator. So you have so many innovations in the pipeline. And when we think about, let's say, peri-implantitis as a topic, yeah, surface technologies that are maybe more resistant to inflammation, that support more the tissue support, decontamination tools, decontamination protocols, GalvoSurge, GalvoCare, so all these tools for the future, I think they have a high relevance that drive also the implant success even further. Yeah. So I think oral infections, prevention of infections at the end, all modifications of your implant system have one target: to improve success and survival. That means you overcome the risk for inflammations. So at the end, we have the same sweet spot.
Yeah, I think we're dreaming a very similar dream. So
Yes.
this topic of finally understanding the impact of systemic oral infections for I would say systemic diseases. This is still underpenetrated, and I think it's not. People know it, and it's not new. And we learn quite a bit in the last let's say years, but it's not yet common practice. So probably this will also have a massive impact on the role of the dentist in general health, and that's probably also a slower process to establish this.
And this is where we need your innovation. So you see the way, and you have just to support it by technologies, by procedures. And at the same time, the people are always dedicated to talking about aesthetics, pink aesthetic scores. I'm always asking, well, think about the medical component of it. Think about what it means for a patient if you treat an oral inflammatory lesion. So this has a medical impact, and you do it on a daily basis. So focus on outcome measures, focus on principles that put this more in the forefront. This is also for a benefit for the patient.
Yeah, not just the aesthetic aspect. This is, of course, easier to understand and accessible for the patient, and that's probably why it's a primary driver.
This really gives me a hard time to see that dentistry has such a strong pillar on aesthetics, which is good, but it becomes too strong.
So biology should be balanced.
Biology and the medical component. Yeah. And putting implants, nobody thinks about what comes when you replace a missing tooth, not a tooth, a missing tooth by an implant. What is the true function? Is it aesthetics? Of course. But what is more? What would you say? What is the benefit?
Chewing, speech,
yeah, chewing.
And then, and
speech,
biology.
but chewing. What about chewing? So what is the main component?
Nutrition intake.
Nutrition, of course.
Oh.
But there is more. What is more? There are many studies indicating when you lose teeth, when you lose the masticatory function, you have a lack of training of specific areas in the cortex, in the brain. So you get a degeneration of these areas that have the function to get this feedback from the chewing and from the masticatory function, and they degenerate. So when you reestablish the chewing function by means of implants, you even counteract the degeneration of cortical areas. That means we can keep the function, so dementia correlates also with the number of teeth that you lose. So restoring teeth by prosthesis or by implants
it's very interesting.
has many more components than just the aesthetics. It also has
obviously mental health.
Mental health, exactly. So dementia correlates with tooth loss and also with oral infections, as one example. This is by far more fascinating than talking about
Aesthetics.
the tooth color and the aesthetics and the pink aesthetic scores. Where is it, the 9, 11, or 12? It doesn't matter. But the mental health is also something that is
the question, the question triggers with me, and that's maybe for another podcast, right? Is, then after 40, 50 years of progress in implant dentistry, still from, let's say, 100 patients that would benefit from implants, still only 7 to 8% do receive an implant, and we create this impact that you just described in only 7 or 8%, and 92 to 93% of the patients, do not benefit from
Yeah.
from what you just described, I think that's just a
How can
question.
we change that?
It's still a question that I think we should debate as
Yeah.
a group as well.
You just have to put what we have scientifically on the table and say these are the benefits of restoring the masticatory function of a patient. And this goes far beyond
powerful.
the aesthetics, far beyond.
And removing, I would say, chronic infections. So,
Yes.
yeah.
So let's move to the next chapter. We always have also questions from the audience, and we got two this time, which we selected, which we liked. I start with the first one, which is a nice coaching question, actually, and I would add something to it. The question is, if you were starting your career today, Frank, what would you approach differently? And what I would add is, based on this, what's your recommendation to the next generation of young dentists?
So I'm not sure whether I would go back to the decision to proceed with dentistry again. So this is
Maybe pilot.
Not from the perspective of today. I would rather go more into the medical field. But still, I think this link, dentistry and medicine, is still worthwhile. So we can still change and improve the way how we see, how we look at dentistry. But I would say the most relevant point that I would change is I would more early on focus on translational research, because at the end it's really important that you understand the clinical need, and you make the link with the experimental work. I think this is the sweet spot. This is the sweet spot. I've spent some years, maybe too much, on the experimental side, so I'm now more on the clinical side. And I think this is something that also attracts many young clinicians. You attract them by far more with clinical procedures than with the lab work. And I think that defines dentistry in the best possible way. The possibility to do translational research.
Okay. Good.
We got the second question, and I might know a little bit of the answer based on our previous discussion. So the question was for clinicians early in their journey, what should they prioritize first? Technical skills, prosthetical understanding, or biological knowledge?
Yeah, it's a no-brainer. It's a biology. Because the biology is the fundamental basis
for everything.
You can't fool the biology. If you don't follow the rules that the biology definitely sets, you will never succeed. You will never succeed. So spending some time apart from this translational and clinical part into basic research is I would say fundamentally relevant.
Very good.
Good. At the end, we also want to give you the opportunity to ask a question to Straumann or to us, if you have one.
Of course. No, first of all, I would like to appreciate all the work that we did so far. So this is something that is also for me really important, to have reliable, trustful collaborations, and the collaboration that we have had. So it's outstanding. So this, of course, comes with an obligation, and I would like to know, what are your next steps? So where do you want to drive and to navigate implant dentistry in the future?
I would say that's a broad question. I can start, George, if you want. So I think, us, George and myself, driving pretty much the innovation agenda that we have in this company. There are a lot of things in our mind. I think one topic, clearly what we see is, to kind of also complete the treatment possibilities in more and more extreme cases, like super severely atrophic cases, mandible, maxillar, and to provide also tools so that more and more patients can benefit from this. And we are pushing a bit, trying to push the boundaries. I think that's certainly one. area, and I would say another area is, of course, we always have to work on disrupting ourselves, I think.
It goes a bit back to Andreas what you said before with the 7% penetration rate. So how can we change that? What are the reasons why it is not yet, I would say, further established? It's about patient access, it's about education, but it's also about product innovation, workflow innovation that we want to push. And I think in our discussion we already touched upon some of the very fascinating topics also for the future. So this making sense out of intraoral signals for general health. I think that's for us, let's say, a huge field which we still don't know exactly, what role we can play. But we just, sometimes it begins with this feeling, okay, there is something, and we need to go deeper. We need to understand better, what could our contribution be actually in that field. And it goes exactly in the direction that you mentioned before. So we see how important oral health is in general. And I think we do provide a certain set of options to treat oral complications. But what else is there that we need to, let's say, provide? And also, how can we, to a certain degree, democratize access to those treatments? Because that's not done yet. And I mean, before we had a quick discussion on the different markets, on what's happening in the US market, in the China market, or in underdeveloped markets, and what is our role there? How can we help actually to make or provide access for patients to that kind of treatment, which of course goes always through the dentists. So how can we support the dentists to also use those technologies? I think that's what's driving us, and
Many
what the
more
future
things.
will bring. Yeah.
Yeah, so it's both. We have to go deeper and broader and, at the same time, yeah. Which is very exciting, and it's also exciting to collaborate with people like you, Frank. I mean, this is also, I mean, you said it before, you get the inspiration a lot from your clinical work as well. And it's the same for us. We get the inspiration from working with clinicians like you. And I think also conversations like today that are not confidential, but others that are confidential are really fueling our ideas and pipeline. So thanks a lot for many years of partnership, Frank.
Yeah, thanks. So we are thinking in the same direction, right?
Yeah.
That's good.
Definitely.
Good to know.
So before we wrap up, George, what stood out for you today?
So, I mean, first of all, Frank, what stood out to me, what was a central topic that we discussed is really, I think you have a very high sense of responsibility for, let's say, the patient community. And you drive this in many different ways. So I perceive you, and that's not just from today, but your, let's say, detail orientedness, your striving for perfection leads to actually results that actually can be used to build one on top of each other. And you do this now since many decades, and I think this is very fascinating. So this academic basis that you talked about, I believe that also defines you on how you work and what you want to achieve, because this is the foundation then for many others to follow on those steps and build on what you actually built. The other topic that I think is very central for you is it's not about oral health, it's about oral medicine, and it's about general health. And also the question in terms of what would you change? Maybe you would start in medicine. I think that shows a bit how you think in terms of very, I would say, connected way of looking at disease, at health, at patients. And this was really standing out for me. Also, I learned a lot about, restoring or defeating dementia by also restoring chewing function. Yet another connection that I wasn't aware of. And I think that really is for me a bit, a strong signal of who you are and the level of detail and interest that you're having.
Thank you.
Thanks for the summary. I would only add one topic that I always observe also when we talk, and this is your passion also for developing talent in your team in Frankfurt. And I know how important this is for you to help young clinicians to progress. And I think it's so important to build the future. So thanks a lot for being with us, Frank.
Thanks a
Thank
lot,
you.
Frank.
It was my pleasure.
Exactly. And thanks to the listeners. Thanks for listening in today. I hope this was an inspiring episode. If yes, please recommend it to a friend. And please always feel free and invited and warmly invited to drop a note and a comment and a question on our Straumann Global Instagram channel, and watch out for the next episodes to come around on Apple Podcast, on Spotify, and on YouTube. Thanks a lot for listening in.